Hello, everybody. So I'm back with the second lecture on cognitive behavior therapy. Before I proceed with the lecture, I would like to thank all those who joined the Facebook group. And I would especially like to thank those who are helping me to set up that group and making an effort so that we can get this project rolling. For those who haven't watched the first lecture, I really would like to encourage them to watch it because it offers a lot of basic introductory information. So before I start this lecture, I want to mention that I will be having clinical cases that I will use for educational purposes. These cases are self-made. They are not real patients. And this is a method that I use for teaching. So we will, the important aspect of clinical cases is that it provides an opportunity for students to engage. So I really would like you guys to start engaging in discussion and start commenting. And don't be shy. It's a small group, and everybody in the group is at least most of them are there to learn. Some of them are there who already have the knowledge and skills, and they are going to help me to facilitate discussion. So don't be shy. Now, this presentation, I'm going to use a case, and this is a case of Raj. He is a 25-year-old single male who lives with his parents. His older brother, who is married, a younger brother, and two younger sisters also live in the house. Raj reported feeling depressed for the last couple of months. He also reported having a disturbed and non-refreshing sleep. He thinks he might be eating more than usual, but denied any noticeable change in his appetite. He denied any suicidal thoughts. He reported feeling stressed for being unable to find a job after completing his master's degree in computer sciences over a year ago. He spends most of his day watching television or on social media. He reported a strained relationship with his older brother, and lately his father has been a bit tough on him as well. He reported smoking cigarettes but denied any other substance use or abuse. He's not taking any medications. And so you assess Raj to have depression, and you offer him psychotherapy, and he's willing to receive it. Now, so you set up an arrangement for psychotherapy, and this is, say, what you do. So you offer him attentive and sympathetic listening. You reassure him. You try to support him. You try to support his healthy defense mechanisms, his healthy behaviors, and you're just trying to uplift him out of depression. And the rationale you do that is you want to provide him emotional support. You offer him a few suggestions to help with his constrained relationships with his older brother and with his father. And here again, your rationale is that you want to improve the relationship and reduce the stress that it is causing Raj, and hopefully that will help with his depression as well. You educate him about the risks of smoking, and you also provide him information about depression. So here you basically offer him this information to educate him. And finally, you offer him a few methods on alternative thinking with regards to his worrying. And you also make a few behavioral suggestions related to his smoking lifestyle. And here your rationale is that you want to tackle his worrying, sleep problem, and some of other problems behaviorally. And all this seems very good. It's productive. You are very good in doing what you are doing. So you develop a good therapeutic relationship with him. And Raj is also feeling better. Now let's try to understand what you are offering in more technical terms. So you offered these 4 distinct type of interventions. The first one was that you offered him attentive and sympathetic listening, and you provided him reassurance. And here what you're doing is basically an intervention similar to supportive therapy, but not necessarily supportive therapy. Because supportive therapy, though commonly it is used in a manner that, because you're trying to support the patient emotionally and you're often trying to lift him up, that's supportive. But technically, supportive psychotherapy is a spin-off of psychodynamic psychotherapy. So it uses a lot of psychodynamic interventions specifically in the process. You offer a few suggestions to help him with his constrained relationship, and this would technically qualify as interpersonal therapy. But again, it is not technically interpersonal therapy, because true or proper interpersonal therapy requires full assessment. Sometimes it can take 3 full sessions to assess, or even longer, to assess the relationship, to assess how the person relates, to assess all the dynamics around them. And then you set up a 12, 16, or 20 week or a predetermined, like, structured sessions that specifically focus on those interpersonal issues. Thirdly, you offer him some education around his risk smoking behavior and some other information about depression. And so you offer him psychoeducation, and this is pretty much consistent. Most health professionals will do that. Finally, you offer him alternative ways to think, and you offer him, so you make a few behavioral suggestions about his sleep problem or about his smoking. And here you are employing cognitive behavioral techniques, but you are not offering him cognitive behavioral therapy, because proper structured cognitive behavioral therapy, as we will discuss in the next 20, 30, or even more sessions, is a very specific type of psychotherapy, and one has to have a lot of back knowledge, understanding, and experience in it to offer it. So what you are offering, some would say it's supportive therapy, but because supportive therapy relies on psychodynamic principles, it's not really supportive therapy. Some may use the word counseling for it, but I avoid that word, because counselors, at least in the developing countries, they can also be trained in specific psychotherapies. So it's not simply that counselors only offer supportive counseling. But so I prefer to use the word non-specific psychotherapy, and that's what you offered to Raj. Now, how non-specific psychotherapy differs from specific psychotherapy, I will discuss in a few of these lectures, but I want to make major points here. So non-specific therapy is generally for mild conditions. It's also for situations that are temporary and situational. So non-specific psychotherapy is for mild, transient, or time-limited conditions. For example, if someone is going through an adjustment disorder, or Raj, the information we have so far about him his situation seems to be transient. Sooner or later he'll find a job. Once he finds a job, hopefully his relationship with his brother will also improve, and his depression will also get better or resolve completely. So this is he's a good candidate based on the information we have about him so far. In terms of specific psychotherapy, it is offered in cases that are relatively more severe, relative to mild. So they can be moderate or severe in technical terms. Many moderate conditions show very good response to CBT. Some conditions show very good response to interpersonal therapy and other forms of therapy. So similarly, specific therapy is offered in situations that we can't really say they are going to resolve after a given time. So there are chronic conditions, there can be chronic interpersonal difficulties, chronic problems in terms of the use of defense mechanisms or personality construct, or chronic problems in terms of behavior and thinking. So we will offer more specific therapies in such situations. For non-specific therapies, benefits are situational and transient. So you simply basically try to help the patient stay afloat till the situation resolves, and hopefully after the situation resolves, the person will get better. Now, if the situation doesn't resolve, or if the situation happens again, the person would not have really developed many skills to tackle it, and he will develop symptoms again. Versus in specific type of psychotherapy, you specify what you want to address, and you work on it according to a model that suits it the best. So if you want to modify the defense mechanism or the personality construct, you may want to do psychodynamic psychotherapy. If you want to modify certain aspects of behavior and thinking in a long-term manner, then CBT would be a good option. But it is a structured type of therapy that you will have to identify what you are treating and set goals on how to treat it. Finally, non-specific type of psychotherapy requires very basic knowledge and skills. And in developed countries, many professionals offer basic mixed psychotherapy. And they can be social workers, nurses, nurse practitioners, occupational psychologists, school psychologists. Like there are many other non-psychologist businesses professions as well who offer it. Doctors offer it. Even clergy can offer it. The ones who are trained. And because non-specific psychotherapy works in transient, mild conditions, and most developing countries have not really set up a structure or regulation around it. So most of these patients in developing countries go to faith healers or religious people or other non-professionals who are not necessarily licensed or regulated. So it's basic form of psychotherapy. Versus when you offer specific psychotherapy, it requires a good understanding of the type of therapy you are offering. So if you want to offer CBT, it requires a lot of knowledge about CBT. It requires extensive training about it, and it requires a good amount of experience with it. In the developed countries I worked, usually for these therapies, one has to go through 30, 40, 50 hours of face-to-face lectures, then has to read a few hundred pages of material, has to engage in discussions, clinical discussions, and then on top of it has to go through a year or 2 years of supervised therapy. So, and even after graduating or after one gets into individual practice, some people continue to see some supervisor on just professional basis freely, just to keep polishing their skills. And I don't know what the situation is in developing countries, but I know it's not really optimal. Here the talk basically ends here. But before I end the session, I would like to make 2 points. First, please note that we will keep Raj's case and we will further build on it. So don't forget Raj. And on the same line, let me know what you would like to know more about Raj, or how would you like to assess him further, and leave those in your comments, and I might integrate some of those into Raj's case, and we will then have good discussion around it. Finally, thank you once again for watching this video, and please share this information with your friends or colleagues who you think will benefit from them. Bye.